Hi, my name is Rachel Whalen. I'm going to be doing a musculoskeletal and neurological assessment on my patient Robin. I'm going to start with the upper extremities. So at each joint, I'm going to inspect. I'm just going to look at the contours of the joint. Is there any redness? Is there any swelling? Any deformities? Assessing the size of each joint. And then I can palpate. I'm going to palpate the radial artery and the brachial artery. So the radial is on the thumb side of the wrist. It's medial to the radius at the wrist is where you can palpate. And then the brachial artery you'll find in the antecubital fossa. Just medial to the biceps tendon. Now I can look at her muscle strength and range of motion of her upper extremities. A good way to test muscle strength for symmetry is to have the patient grip your fingers and then have the patient squeeze. And again, you're looking more at symmetry here. Okay. Now I'm going to look at her finger range of motion. First I'm going to have her just not at the wrist but with your fingers. I'm going to have you start by doing extension. Not at the wrist, just your finger, and then flexion. And then we'll do abduction, stretching the fingers out. Adduction, going back to midline. Good. Now with the wrist range of motion, I'm going to have her do extension, flexion, and then abduction, going out, adduction, back to midline. Okay. And then we can move on to the elbow. So extension. She's gonna, we'll start with flexion. Flexion, you go up and touch your, and then extension, come back down. Yeah. And then we'll do the pronation, supination. So, pronation, supination. Good. Now we'll do the shoulders. So first we'll do extension all the way up, and then flexion, take it down and back behind you as far as you can. Good. And then abduction, so out and away. Good. And then adduction, cross it over your body. Good. Then we'll look at external, internal rotation. Internal, I'm going to have you take this with this hand, come up and scratch the back of your neck. With the same hand, go behind you and touch your opposite, look down and touch your opposite shoulder blade. Good. Then we can move on to the lower extremities. So, let's see, have you face that way. Move the camera here, down. So I'm going to be looking at her, first I'm going to inspect. I'm looking for symmetry between the two extremities. I'm looking at hair distribution. I'm looking at the venous system, varicose veins. The venous system should be flat and barely visible. And I'm also going to palpate here. I'm going to palpate the popliteal. That's at the back of the knee, the popliteal fossa. It's medial. Then I can palpate the posterior tibial at this time too. That's right at the groove between the malleolus and the Achilles tendon. Then I can also palpate the dorsalis pedis. That is lateral and parallel to the extensor tendon of the big toe. Now I can look at her muscle strength and range of motion in her lower extremities. So I'm going to start with doing her some push-pulls with her feet. So I'm going to have you push on my feet like you're pushing on a gas pedal. Good. Now I'm going to have you kind of work against my own resistance. Pull your toes up to your body. Good, good, good. And then we can do ankle range of motion. So flexion. I'm going to have you point your toes up. Extension down to the ground. Good. And then I'm going to have you draw a circle, like an imaginary circle. Yes. That is the inversion, eversion. Now I'm going to do the knee range of motion. So extension, I'll have you come up with your foot, and then flexion, back down. Good. And then we're going to do abduction. So you're going to go away from the midline. Good. Adduction, back to the body. Very good. Now hip range of motion. So for flexion, they would the patient could lie on their stomach and they would bring their leg up and out, or actually just straight back out. And then for extension, they could bring they would be laying on their back, bring the leg up. And then for abduction and adduction, you want to lay on the side and take the leg straight up, or it would be out. And then for adduction, you kind of take the leg across the body a little bit. And then for next, I'm going to look at her spine. So I'm going to have her stand. So looking for any signs of scoliosis, kyphosis. I want the spinous process to be straight. I'm looking at the curvature. I want it to, the curvature to match just normal. So range of motion here, I'm going to have the patient do a full circle with their neck. Yeah. Then I'm going to have her touch her ear to each shoulder. Next for gait, I would have the patient with their shoes on. I'd have them walk 10 feet, then turn and walk back. It should be smooth, rhythmic, effortless. You don't want to see their arms out or a shuffling. Now I'm going to do the Romberg test, so I will have the patient stand with their feet together, arms out at their sides, and then I'll have them close their eyes and hold that position for 20 seconds. And if they start swaying or lose their balance here, that might be indicative of something more serious, like okay. So the Babinski reflex is seen, it can be seen in infants from birth to 24 months. You check that by taking your finger along the lateral edge of the foot up to the ball, and a positive Babinski reflex would be when the infant's toes fan out. That's what you're looking to see. So for the coordination and movement section of this, for my patient, I'm going to start with rapid alternating movements. So I'm going to have her take her hand, and with her thumb, she's going to touch each tip of her finger. Just kind of go back and forth. So that should be fairly rapid, accurate, smooth, rhythmic, and it is. Now I'm going to have her do the finger to nose test. So I'm going to have her start by touching her index finger to her nose. And I want her to touch my finger, nose, finger, nose, finger. So you're switching where your finger is each time. Good. And that was smooth and accurate as well. Now we'll do the heel down opposite shin test. So I'll have the patient take their heel and onto their opposite shin. They will go straight down to the ankle. But what you're looking for here is that they do so in a straight line. Now for the position sense of fingers, I'm going to take the patient's hand. I'll have her close her eyes, and then with one of her digits, I'm going to move it ever so slightly in a certain direction. I'll have the patient tell me if it was moved up or down. And you could do that a few times. People should be able to sense within just 2 to 3 millimeters. They should be able to sense the movement. So for sensation, I would check the face, legs, hands, feet. I would have the patient close their eyes, and then using either light touch, or some people use cotton wisps. You would touch at certain places, and you'd have the patient say, now when they felt the touch. Try to avoid using leading statements like, can you feel the cotton now, or can you feel the pinprick now? That would give you more accurate results. So for deep tendon reflexes, for the brachioradialis, I would hold the patient's thumb to suspend the forearm, and in relaxation, I would strike the forearm directly, and a normal response here is you'd see flexion and supination of the forearm. The patellar, I would strike just below the tendon. I would strike the tendon just below the patella, and a normal response here would be an extension of the lower leg. And then for the Achilles, I would have the patient's, this would be easier if the patient was lying down, but I would have the knee flexed, the hip externally rotated, foot in dorsiflexion. I would strike the Achilles tendon, and the normal response here would be a plantar flexion of the foot against my hand. And that concludes my musculoskeletal and neurological assessment.